Okay. Good afternoon, everyone. Can you hear me okay?
Yep.
Okay, brilliant. Good afternoon, and let me just let other people in who are in the waiting room. Okay, great. Thank you so much for joining us today. And so we encourage everyone to keep, please, their video on if it's possible, as it adds to the sense of community, and it would be wonderful to see you as well. Welcome to the next lecture in the MAHSC Inaugural Lecture Series, which celebrates the remarkable contribution of our honorary MAHSC clinical chairs. So these honorary clinical chairs are awarded annually by the Promotions Committee of the University of Manchester's Faculty of Biology, Medicine and Health, distinguished individuals across Greater Manchester. And each honorary has made significant contributions to their clinical specialty, demonstrating excellence in research, education, and clinical practice. Today, we are pleased to welcome Professor Sophie Parker from the School of Medical Sciences, Division of Developmental Biology and Medicine. She will be introduced by Professor Sandra Bucci. In our second talk, we welcome Professor Simon Carley from the School of Medical Sciences, Division of Cardiovascular Sciences, who will be introduced by Professor Ellie Cartwright as the head of the division. So please feel free to submit and put your questions in the chat box, and we will make sure to address them at the end of each talk. We look forward to celebrating the achievements of both of our professors today. I will hand it over to Sandra, and thank you so much.
Thank you. Well, it's my absolute pleasure to introduce Professor Sophie Parker, who's an expert clinical psychologist, academic, leader and teacher, whose dedication and intellectual rigour have earned her a MAHSC clinical chair. She's made remarkable contributions to early intervention in adolescent mental health, advancing knowledge and inspiring her peers and students alike. So Professor Parker co-founded a specialist psychological therapy service for young people, the first of its kind in Europe. As director of the Youth Mental Health Research Unit and a consultant clinical psychologist in Greater Manchester, she's built a research unit truly integrated with clinical practice. Her group is pioneering new treatments in early detection and prevention of long-term difficulties in young people, especially those at high risk of bipolar disorder. Her research has contributed to national and international clinical and policy guidelines, transforming NHS services for young people and their families, and the assessment measures and the therapy models she's developed are being used worldwide. Professor Parker is an inspiring educator and supervisor, and she's guided numerous researchers and clinicians towards success. Perhaps most importantly, she puts service users at the heart of her work. She's dedicated to reducing inequalities in healthcare and careers through outreach, through mentoring school-age children and providing work experience places, just to name a few. Now, when she's not cooking up groundbreaking clinical research studies, you might find her cooking up a spectacular cake or generously giving her time to supporting the swimming community. Professor Parker is a dear friend to many of her colleagues, a testament to her kind and generous spirit. And so it's my great pleasure to welcome and congratulate a truly deserving Professor Sophie Parker as she presents her inaugural lecture. Sophie, over to you.
Wow, don't know if I can follow it, Sandra, but thank you so much for the incredibly warm introduction. Can you see my slides all okay?
Yep, look great.
Oh, perfect. Oh, so thank you so much for having me. It's a great pleasure to say hello to my colleagues, my friends, my family who are joining the call. And as the director of the Youth Mental Health Research Unit at Greater Manchester Mental Health Trust, I'm deeply honoured that the work that we've contributed has led to my appointment as MAHSC Clinical Chair at the University of Manchester. This milestone holds a special meaning for me, as my individual path to get here has not always been an easy one. And it does particularly demonstrate how education can open doors, opportunity can create possibilities, and resilience can transform challenges into achievements. My achievements are, of course, built upon the foundation laid by previous generations and my family, my grandparents in particular. They were steadfast workers, shaped their communities, worked the land, built roads, contributed to the fabric of society in ways that, while maybe understated, were no less vital. Their dedication and resilience laid the foundation for the opportunities I've been able to pursue. And I particularly remember days in my grandparents' gardens, the ones pictured here. They taught me about nurturing growth, where I too could transform and be free and play. They showed me that every plant, like every person, has its own time to flourish. Some need more shades, others more sunlight, but all need patience, attention, and care. In that garden, among the steady rhythms of the seasons and the quiet wisdom of tending to living things, I learnt that growth isn't just about the end result, but it's about creating the right conditions for potential to bloom. Their garden wasn't just a place of cultivation, but it was a place of possibility, where small seeds with proper care and time could transform into something, where perhaps I could transform into something. So this personal history has profoundly shaped my approach to mental health research. I see in every young person the potential for growth and resilience, much like the potential others saw in me. It's driven my belief that with the right support and intervention, we can fundamentally change the trajectory of young lives. This belief has been the cornerstone of my career, focused on the prevention and early intervention of serious mental health problems in adolescents. It's a mission that feels deeply personal. It reflects not just professional goals, but the values of hard work, community service, and creating opportunities that I was afforded by important figures in my life. So I'm going to walk you through our work. Using the metaphor of the growing garden, we'll explore the seeds that we've planted in youth mental health, how we've cultivated new approaches to care, the first fruits of our results, and the fuller harvest we see on the horizon. Just as a garden needs careful tending, we're nurturing these innovations to create sustainable growth in mental health care. This commitment to prevention has yielded really, truly transformative results. One of our most significant contributions I'm proud to have been part of is the demonstration that psychosis could be delayed or prevented by offering cognitive behavioural therapy for at-risk adolescents. This research wasn't just an academic exercise. It's directly led to these interventions being recommended in NICE guidelines for schizophrenia and psychosis in adults and children and young people. It's been incorporated into the NHS long-term plan, and now young people can access assessment and NICE approved care within 2 weeks of referral. This is truly transformative from what a young person and their family would have previously expected to receive from the NHS. It's a real-world example of how pioneering prevention can reshape the landscape of youth mental health care, opening doors of opportunity, much like education perhaps did for me. But as we survey the current landscape of youth mental health, we're confronted both with challenges and opportunities. So we know that the prime period for the onset of mental illness is during the maturation period between childhood and adult years, with most occurring by the age of 25. So this statistic alone underscores the urgency of our work in this field. We're witnessing global patterns which are profoundly impacting young people, rising intergenerational inequality, pervasive influences of social media, employment insecurity, climate change. These forces are really shaping or reshaping the mental health landscape for young people worldwide. Mental ill health accounts for at least 45% of the overall burden of disease in young people aged between 10 and 24 years. But within this challenge lies an opportunity. We're not just talking about treating illness, we're discovering the cultivations of what experts are calling mental wealth, the collective cognitive and emotional resources that determine our society's future. By focusing on youth mental health, we're investing in resilience, creativity, productivity of entire generations. So as we look to transform the landscape, we can turn to something like cancer research to see what's possible. Their funding model really shows what sustained investment could achieve: remarkable innovations, transformed patient outcomes. But the stark reality is that cancer research receives £612 million of funding, which equates to about £228 per patient, whereas mental health a bare 124 million in comparison, which is £9 per patient. And with only 26% of this already limited funding going into youth mental health, we're facing a critical challenge and an unprecedented opportunity. This funding gap, whilst deeply concerning, shows us exactly where targeted investment could spark the same remarkable breakthroughs we've seen in cancer care, transforming the lives of young people for generations to come. And the stakes couldn't be higher. With youth mental health crisis, this funding disparity threatens not just an entire generation, but our society's mental wealth for decades to come. So by applying this a proven funding model to youth mental health, we could spark the same momentum for breakthrough discoveries. Picture what we could achieve with sustained investment around early warning signs, evidence-based interventions, treatments that could really change the trajectory of a young person's life. So I'm committed to driving this change through three critical paths: raising awareness of youth mental health, conducting cutting-edge research, and building capacity in our workforce. This commitment is already taking shape in our groundbreaking work. Building on our success of psychosis prevention, we're breaking new ground in helping young people at risk of bipolar disorder. This NIHR-funded project, first of its kind worldwide, is testing interventions across 5 NHS sites in the UK. This is pioneering prevention in action. Rather than waiting for conditions to fully develop, we're identifying those at risk and stepping in early. We're aiming to mirror the same success we've seen with our at-risk mental state care pathway for psychosis, creating a new gold standard of rapid care for young people at risk of bipolar disorder and their families. By developing and validating these new treatment approaches, we'll create a blueprint that other healthcare providers can implement. In the chapter in this upcoming book, we set out the rationale and evidence, the importance of offering tailored interventions for distressing mood swings, people who might otherwise go on to be misdiagnosed, leading to unhelpful treatments, or typically actually no treatment at all. The chapter illustrates our unique and novel approach, and it's brought to life with illustrations of young people experiencing these sorts of difficulties. In the chapter, we follow a case of Alex. She's got difficulties with low mood since she was 16. She has periods of high mood where she's full of exciting ideas, racing thoughts, and a need to get things done. But she oscillates between feeling unable to do anything in low mood and then feeling productive but struggling to remain focused during her high mood periods. She's lost her job. She's had multiple periods of sickness, which have led to this. So through the use of the model of the CBT bar intervention, we focus on key appraisals, internal states, key behavioural strategies, and this has all got to be delivered within core principles and values, building trusting relationships, validation, normalising, and collaborative goal setting. Alex reports benefits of increasing awareness of her mood, appraisals and behaviours in relation to facilitating choices of her actions. She becomes less fearful of time doing nothing. She's able to actually start sitting still. She particularly values the therapist's flexibility, understanding and non-judgmental approach. This is exactly the kind of forward-thinking prevention we need, catching issues early, intervening effectively, and planting the seeds for better mental health outcomes. And this isn't just research, it's a blueprint for transforming a young person's life. We can really make a difference. So as we cultivate new approaches, our focus is on developing and refining strategies, particularly for conditions like psychosis and bipolar disorder, but also to the prevention of other poor outcomes for young people in our community, our inpatient areas, our forensic settings. In the Youth Mental Health Research Unit, our vision is to ensure the integration of research within clinical care and practice. This integration is crucial for developing and implementing effective early intervention strategies. For instance, in our research on young people of psychosis, we've developed assessment tools. National training helps clinicians identify people. New tools facilitating global data sharing. Developing methodologies also to meet the needs of a diverse youth population is really crucial. And we're developing new methods and interventions for inclusive practice to increase research participation from diverse communities. Working with an amazing group of young people from ethnic minority backgrounds, we've developed an animation which I'd just like to showcase now, one of their pieces of work that is truly amazing.
Did you know that UK ethnic minority groups are typically underserved by research? The UK has a diverse population, and it is important that this is represented in the work that we do. In our previous Bipolar at Risk trial, BART, we found that low mood and functioning was improved with CBT. CBT is a talking therapy, helping people achieve their personal goals and navigate personal struggles. However, findings from the first trial were not well representative of UK ethnic minority population. This time round, in BART 2, we want to make sure that our findings are as representative as possible of the UK population. We are looking for people aged 16 to 25 who experience distressing periods of high and low mood, or you may experience only periods of low mood and have a family member diagnosed with bipolar disorder. If you take part in BART 2, you will be allocated to one of two possible outcomes: CBT plus usual treatment, or usual treatment alone. Previous participants said that they felt valued and understood after taking part in the first trial, and that it helped reduce stigma around their experiences. You have the power to choose where you are seen and how you are communicated with. Everyone who wants to take part in the trial will have the opportunity to meet with a research assistant to assess whether the trial is right for you. Your involvement in BART 2 is vital to ensure that our research is as representative of the UK population as possible. This animation was developed with the patient and the public involvement group made up of young people who belong to UK ethnic minority groups. For more information, visit our website.
So that's just one of the pieces of work that they're doing. But also what's really important as we evaluate these approaches that has the potential for greater impact, not just on one single trial, but across into a wider field of youth research, which is what this group are doing. We're also applying rigorous outcome monitoring to continuously evaluate and improve our intervention approaches, allowing us to refine our methods and provide the most effective support to young people at risk of serious mental health problems. These strategies represent a significant advancement in our approach to preventing and intervening early in serious mental health. By focusing on early identification, inclusive methods, and continuous improvement, we're pioneering more effective approaches to early intervention and prevention for all young people. So the impact of these pioneering approaches in early intervention has already become evident. Our work on psychosis prevention, we've seen significant reduction in transition rates to psychosis among high-risk young people. We're seeing economic benefits, and our research suggests that for every £1 invested in these early intervention programs, you can see a substantial return in reduced healthcare costs and increased productivity over time. Importantly, these programs are also contributing to public awareness, destigmatization efforts by framing mental health in terms of early support and prevention, shifting the narrative away from fear and shame towards proactive health management. And perhaps most crucially, these approaches are helping us build resilience in our youth and mental wealth in our society. By intervening early and providing targeted support, we're equipping young people with the tools they need to navigate an increasingly complex world. But the impact of our work extends beyond individual patient outcomes. Our research unit has significantly grown from original 3 members to significantly more people over time. Mentoring early career researchers, supporting service user researchers, and equipping NHS staff from various professions to get them working into our communities beyond healthcare and academia, working into mentoring diverse school students across Greater Manchester, research skills and career development. But this capacity building is really crucial for sustaining and expanding our efforts into transforming youth mental health care. So as we look to the future, the potential for transformational reform in youth mental health care is immense. We envisage a global strategy that leverages these early intervention and prevention approaches but they need to be adapted to local contexts and resources. Imagine a world where every young person has access to evidence-based mental health support, where early intervention is the norm rather than the exception, where mental health receives the same priorities as physical health resources. But this does require collective action. As researchers, clinicians, policymakers, community members, we each have a vital role in pioneering this work. Throughout my journey, I've been shaped by countless inspiring figures. My family, who both inspire me and whom I hope to inspire, but particularly Tony, Lula and Buddy, and Emma. My work family, whose wisdom I've learned from and whose fellowships I really cherish, and the many remarkable figures who I've met along the way, who've opened doors for me, created opportunities, maybe encouraged resilience when I've perhaps doubted what was possible. But in particular, so many people with lived experience and their families. I really couldn't thank all of these people enough. We're not just transforming the landscape of youth mental health care, we're cultivating the next generation of researchers and clinicians who will carry this work forward. I challenge each of us to consider our roles in this transformation, whether there's research advocacy or direct intervention. Every action can matter. The vision I've shared today of early intervention and preventative mental health care for every young person is ambitious, but through our collective efforts and through a rigorous research, community engagement, an unwavering commitment to serving underrepresented populations, I really believe it's achievable. Together we can create a future where every young person has the opportunity to thrive and be mentally wealthy. And returning to my grandparents' garden, where we mobilise each plant to grow into its full potential. Thank you so much.
Thank you, Sophie. What a fantastic inaugural lecture, and a fantastic metaphor that you've carried throughout your life, but also through your work. So we have a couple of minutes to open up for a question for Sophie to the floor. So Sophie, I wonder if you might want to stop sharing your slide. There we go. And then we can see everyone. Hi, everyone. Fantastic to see so many people on the call. So does anyone want to pose a question or two for Professor Parker? Go for it. I know someone wants to ask something. Right, I'm going to kick us off. Or if we, yeah, okay. I can't see any hands. So just oh, Paul, go on.
Yeah, well, look, I just it's not a question really, but I'm the new Dean in Faculty for Health and Care Partnerships, and I'd like to congratulate you, Sophie. It was a lovely lecture. It's an area I don't know enough about as a medical doctor working in largely physical trials, and I think it's really fascinating, this plea to think about the importance of parity of esteem, as I think it's called, really, but actually thinking very carefully about psychological and mental health outcomes in physical research, actually, which is critically important. So I really enjoyed your lecture, and congratulations, Sophie. Thank you.
Oh, thank you, Paul. That's really lovely.
Anyone else for a comment or a question for Sophie? Yeah.
Sorry.
Go on.
Yeah, sorry. So can I just ask a very quick question from Sophie? First of all, thank you so much for your amazing lecture and for sharing your journey with us, which was really impressive. So I was just wondering if there were some of the major barriers to change that you encountered, and how did you overcome them, as an advice maybe for our early career researchers and junior researchers?
I think one of the things that really helped me when I was an early career researcher is understanding that rejection is normal. So where that would be perceived as a bit of a failure, and you can easily give up, but actually to push on and to plow on, and a bit like we do in therapy, really, with young people, saying to people that everything you learn is new, and we develop and we'll talk that through together. And there's been so many people, so many good supervisors, mentors in my life that have helped me to see that particularly funding applications that get rejected, they're really useful. They're not just useful for wallpapering all of our houses, because there's an awful lot of paper that we could wallpaper our houses with, but that you'll have useful lessons and that you can develop and keep forging forward, and to be resilient and passionate about keeping on going.
Of course, yeah, thank you so much.
Any other comments? Oh yeah, Miriam.
That was really inspiring. And the topic's very close to my heart as well. I'm particularly struck by your figures of comparison between spend on cancer research and health research. And this is something. Can you hear me? This is something that's kind of concerned me for quite a long time, and I was just wondering, you know, what are your thoughts about how we might go about addressing that imbalance? And is there anything that your research unit is kind of currently doing to approach that?
I think one of the main things we're doing is being part of the efforts to gather more funding. So we don't want to take any funding away from other really important health care innovations that are being researched, but by being part of a group who continue to put in applications, put in funding, and particularly to work with young people to harness their voice and their families' voices, to really garnish that kind of investment that we want to see. So that's what we're sort of doing, and trying to build the capacity within the workforce to gather more momentum and more people all trying to vie for that important opportunity. I think is really important. But also, I guess, to particularly get the message out there of how important it is, what we might be inheriting in societies to come if we don't work for our young people and really help them to really feel integrated and to be part of their own lives and what they want to be doing.
Thank you.
Okay, any last minute? Yeah, go on, John. Last question.
Unmute. Hi, Sophie and everyone. Thanks a lot, Soph. That was great. And thanks for inviting me. Is there any potential for taking the sort of ideas and values that you have used in your research at that age group to an even earlier stage and into schools and so forth? I'm not suggesting for a second you should do that. You seem to be a bit busy. But you know, in general, do you think we can be doing more even earlier than what you're doing?
Absolutely, yeah. And there is loads happening within school environments, particularly. And I think there's loads that we can be doing, lots of different things. One of the particular pieces that I've really loved being part of, and Karina's on the call, is sort of reducing stigma public health call through a theatre piece with young people, engaging them in the conversation about mental health difficulties and challenges from a young person's perspective, through a piece of art on theatre piece called Adam that was made by mortals. Those sorts of things I think are particularly important to open up the conversation, particularly for young people who are already having these conversations, as we all know. So yeah, loads.
Go on, Eleanor, super quick.
Sorry, I'll be super quick. It took me the whole thing to work out to raise my hand. I'm so incompetent. So it's not a question, but just really a comment. So just to congratulate Sophie and just to offer like sincere appreciation for the amazing work she's doing. You know, somebody with lived experience myself of like really catastrophic health problems that started at quite a young age. Looking back on my own sort of recovery trajectory, it was so much about luck, you know, meeting the right people, having the right opportunities, and it could just as easily, you know, almost at the flip of a coin have gone the other way. You know, the next generation have really sort of terrorized, demoralized, confused, overwhelmed young people need a lot more than luck to protect them. And, you know, it's a huge honour and privilege to work alongside like someone like Sophie, who is offering that protection and, you know, making sure the next generation have so much better outcomes. So thank you, Sophie. You're a wonderful personal inspiration. I'm so proud to be your colleague.
Well, it fills me with utter pride that you would say that, Eleanor. Thank you.
Here, I think, Sophie, we all feel super proud to work with you, and anyone who's worked with Sophie knows just what a team player she is: kind, generous, fun, but completely dedicated and passionate and committed to the work. So, Sophie, a huge congratulations. This is truly deserving, and we are all behind you to continue this amazing work.
Thank you, everyone. Thank you so much.
Thank you, Yasmin. Back over to you.
Thank you so much, Sandra, and thank you so much, Sophie. Huge congratulations from all of us. So at the second part of our inaugural lecture series today, I will hand it over to Professor Cartwright. Ellie.
Thanks very much. So it's my real honour to be introducing Simon Carley to give his MAHSC inaugural lecture, and obviously that's in recognition of his award as the MAHSC Honorary Clinical Chair. So as has already been explained, this is a University of Manchester appointment which recognises the achievements of distinguished individuals from the NHS. And it's a really fantastic recognition and one that's absolutely hard won. So to receive such an award, you've got to be making an outstanding contribution to your clinical profession, along with conducting excellent research and quality teaching. So Simon's internationally renowned as an emergency physician. He's delivering care as a frontline NHS consultant, making in adult and paediatric emergency medicine. He's also a major trauma consultant and one of those exciting HEMS consultants with the North West Ambulance Service. So as I mentioned, you don't receive the recognition of a MAHSC chair for excellent clinical work alone. So Simon's widely recognised for his peer-reviewed publications and his really well-established track record as a researcher. But I'd probably say that it's his educational contributions that make Simon stand out as a global leader in emergency medicine. So he's had considerable educational responsibilities at a local, a regional and national levels. So just to give you a flavour of those, so he's held numerous roles within the Royal College of Emergency Medicine over the years, and at the moment he's Dean overseeing all academic activities. He's led a number of educational reviews for the GMC. He's Associate Dean for Health Education England, where he oversees training across 5 of the postgraduate training hospitals in the Northwest. And Simon's reputation really extends globally through his work on best bets and the St Emlyn's evidence-based educational resources focusing on emergency medicine. And his work in these areas is making a real difference. And this was really nicely summarised by one of Simon's international peers. So to quote him, said Simon's work as an educator is world class. Whether through speaking, clinical teaching, creating and curating online resources, producing podcasts and blogs, Simon's consistently learner-centred and effective. He's relentlessly innovative in approach while mindful of sound pedagogical principles, which is a really lovely thing to say about somebody. So collectively, these contributions to clinical excellence, to research and that innovation in education make Simon a very worthy appointee to a MAHSC Honorary Clinical Chair. And on top of all of that, I'd like to also credit Simon with the honour of having the most post-nominal letters after his name that I've ever seen, with his numerous degrees, educational and professional qualifications. So bringing all of that together, it's my absolute pleasure to hand over the virtual floor to Professor Simon Carley. Thank you. Simon, you're on mute.
So thanks so much. Don't know about you, Sophie, but I feel like I'm blushing at the end of that. You're such a difficult act to follow. That was a lovely presentation. And working as I do at the Children's Hospital as well, I couldn't agree more about your conversations about the need to improve the mental health of children. It's something we're seeing on a daily basis, and everything that we're doing on those lines to make it better, wholeheartedly support. Really pleased that we're a centre of excellence for that and pushing the evidence-based agenda forward there, because that's been a passion of mine. I'll chuck some slides up and then we'll have a chat, if that's okay. I was really unsure about what to speak about when we were talking about setting up this lecture. So let me see if this works. If I press play now, that should say life, death and decisions.
It does, yes.
Oh, yeah, so thanks for the introduction. I thought we would talk about something clinical, if that's okay, because I've done a bit of research in different areas, and one of the great things about emergency medicine is you can get involved in lots and lots of different things. So we have done work in chest pain, particularly diagnostics. We've done quite a lot of stuff around the major incidents, and we were heavily involved in things like the Ariana Grande bombing, and a lot of the processes that we used then, came out of the work that was done in Manchester here. Decision making is my passion, and clinical decision making. That's what we're going to be talking about today. But also got involved in the COVID-19 studies, which were really interesting. An awful time, but what a time to be involved in research and to see how research can really impact clinical care in such a short period of time. And here in Manchester, we were recruiters for the recovery trial, which of course transformed the outcomes of patients with COVID-19 in hospital. And we've done quite a lot of work with Delphi methodologies about how to gain consensus in areas where there isn't just the great evidence there. And as you said, we've done quite a lot of stuff on social media, which is an interesting place to operate at the moment. But using new technologies for getting people to learn has been a lot of fun, but has presented its challenges. But I thought we'd talk about clinical stuff today and emergency medicine, because although people here won't necessarily be emergency physicians, I'm sure you're not, but you've all been to an emergency department, I guess. And you know that it's an interesting place to be, and there can be challenges there. And one of the things that really interests me is about how people make decisions and how they come to complex decisions when things aren't necessarily straight out of a textbook. And I'm going to talk you through a case, and the case is based on a case which did exist and did come through our department. All the information I'm going to speak to you about today has actually appeared in the Manchester Evening News. So it is in the public domain, and it's approved for use, but I'm going to change quite a few things to make sure that it's not entirely the same. Now, Sophie mentioned evidence-based medicine. I love evidence-based medicine. Doesn't everybody? It's what we should be doing all the time. The problem is that I'm not entirely sure that people do evidence-based medicine, because when you try and translate what is often a really good piece of evidence, and I'm sure other people here on the call have had a great study that they've done or they've known, and it's just, well, why aren't people doing this? And it's because we have to deal with humans, and humans are a nightmare. Humans get them to do things, to get them to believe what the new evidence is, to change what they were doing before. And at the individual level, I always say that any decision that's made with the patient, what actually happens to the patient is reliant on a individual or a small group of individuals deciding to do it. And we often find in clinical medicine that somebody will say, well, okay, you go to them and say, well, the evidence says you don't need to do that scan to diagnose this. We've got enough evidence. And they go, well, yeah, but in my opinion, I'm not so sure about it. And balancing this thing between the evidence, the systems, the inertia, and getting things to move from, this is a very old diagram, I think it's 1996, but I love it. The triangle of the left of what we do in research, we get all the studies, we appraise them, we put them together, we write the guidelines, but then getting them to the patient at the right side, there's a whole bunch of things that we have to get through. And this translational element, I think, is where we can make really big gains in what we do and actually really make a difference to patients. But let's go for a case. This is a taxi. And one of the things which is always interesting, I find, is people don't wear seatbelts in taxis. I don't know whether anybody here always puts a seatbelt on in a taxi. They often don't, which seems insane because you're getting into a machine where you don't know the driver. And they do crash. And they're interesting things, taxis. They're built like tanks on the outside, which unfortunately means if you're in the middle of one at high speed, you do tend to get shaken around quite a lot if you're unrestrained, which is common. And this is a taxi that crashed in Manchester. It was a high impact here. You can see the rear wheel has been torn off. And although the bodywork hasn't moved that much, this is a big energy injury. And in the back, there's a couple of people. There's a young man there who's got some nasty injuries, got some chest injuries, a little bit of internal bleeding, but nothing too serious. We can manage those with chest drains and stuff. But there is a young lady in the back who's quite sick. She has significant chest injuries with a collapsed lung, bleeding into the chest, bleeding into the abdomen. She's so severe injury, which actually torn one of the main blood vessels in the chest and is bleeding from that as well, which is usually, if not, or very commonly, a life-ending injury. And that's bad. But we see a lot of trauma here, and we get good at this sort of thing, and it can be a bit formulaic. But then the complexity here is she's 36 weeks pregnant. And at that point, you are off pretty much every single diagram, course, APLS, ATLS, advanced life support course that there is, because there isn't a guideline for this. And yet you have to make decisions. And this area of complexity has been studied a lot around the world, not just in medicine, but in things like the fire service and police and military areas, but actually making a decision, because we've got decisions with this lady. Do we deliver the baby now in the A&E department? Do we take them to St Mary's, where they've obviously obstetricians are, or do they need to go to intensive care to see if we can stabilize them? Or do they go to theatre to deal with the internal bleeding, or do they go to interventional radiology, or do they do all of those, but in what order? And you have to make a decision. But there isn't enough information for you to know whether you're right, and you have to make it now, and it is high stakes. So understanding how people make those kind of decisions is really interesting. And there's quite a lot of work that we've done, and a lot of work around the world about judgment, about decision-making in complexity. And we know, unfortunately, there's quite a lot of evidence that we're not very good at it. If you ask the average American, and this is an old study now, it's probably changed, but if you ask Americans how many of them are above average drivers, and the figure that they put in the original studies was 93% of them think they're above average, and not so quite popular in Sweden, about 63%. But we've done this in medicine as well, and we've looked at whether people think they're above average about their clinical practice, and most people actually think they're above average, which of course is statistically impossible. Judgment is difficult. It's difficult to measure, but it can be done. But we know that people make bad decisions all the time, and lots of things. You've got collectively difficulty in doing that. Now, in emergency medicine, it's always particularly complex because of where we make our decisions. And if you think about how a lot of diseases, or even in trauma, how people get unwell, it's got this flow. So there's a biological, take something like meningitis, for instance. The biological onset of a disease is when the bug gets into the body. The patient's asymptomatic at that stage, they don't know what's going on. Then they might have early features of just feeling a bit unwell. And then if you leave that long enough, they become more unwell. They get the classical rash or the classical headaches and the classical signs, at which point it becomes fairly obvious that you've got the physiological manifestation that makes it easy. And if you don't intervene at all, that patient ends up in critical illness and may even die. Now, pretty obviously, you want to catch it at the top end, not at the bottom end. But the thing is, it's really easy at the bottom end. So you have this paradox that actually, as time goes on with a lot of the conditions, the serious conditions that we look at, the disease manifestation becomes more obvious as time goes by. And to some, that makes sense, doesn't it? But it does mean that when you're acting and when you're making your decisions, particularly early on in the process, for us in the resus room of the emergency department, your probability of error increases. And any emergency physician you'll speak to will tell you the story of finding one of the inpatient teams phoning you up the next day and go, God, the diagnosis was this. And you go, oh, how did you know that? Why was I wrong? And you go, well, I've got the blood results back, which we didn't have the day before, or the scan. So you're constantly dealing in this area of complexity, and it makes decision-making very difficult. And also we as clinicians, we did some really interesting research years ago when we looked at the patients who came through the department with chest pain, and how certain were you that this person that you're seeing in front of you has definitely got a heart reason. So you're going to get rises in their troponin levels to say they've had a heart injury. And there's clearly a disparity between the certainty of doctors, which is usually very high, and the actual reality of what's happening. So you'll often hear conversations with people that have an ECG like this with chest pain, and people say, you're definitely having a heart attack. We definitely need to do this. And if we don't give you this treatment, you'll definitely suffer from it. And when you explore this, almost every statement there is wrong. This is almost certainly a myocardial infarction, a heart attack, but it's not definitely. And if you have the treatment, not all the treatments work. And in fact, sometimes the treatments give harm. So actually you might be benefit, or you may lose, or it may make no difference at all. And so exploring these ideas has been one of the big things that we've looked at over the years. And essentially, we talk about ourselves as being diagnosticians in medicine a lot of the time, but actually we're dealing with probabilities. And what we've started to do now is build, particularly Rick Bodie, who works with us here, who you'll know well, I suspect, working at giving clinicians actual probabilities about how likely this person is to have the diagnosis. And then seeing, well, when we started doing this, their faces go, well, I can't deal with the probability. I just need to know whether it's yes or no. And you say, well, it isn't yes or no, it's a probability. You have to deal with it. And going through that and exploring how to do that. And Rick's work now at the moment is actually taking that to patients and asking patients and saying, look, this is the probability of you having this condition. What do you want to do? Do you want to come in and have some more tests? Do you want to go home? That's a research project that's running at the moment with Rick. So really interesting to look at clinical judgment. This is William Osler, who many of you will know, one of the founders of real modern medicine, who said this years ago. And more recently for emergency medicine, I think this is probably true, that for us, it is about immediate impression and how we work with that and the science that exists around it. Let's just give you an even more complexity about how we struggle sometimes. I'm going to give you a couple of case presentations. So this is a chap who's been out in Manchester, had a skin full of alcohol and quite a lot of drugs, and has then been hit over the head. He's not very well. He's agitated, he's unwell, it's difficult to know what's going on. It's difficult to determine whether or not his behavior is due to a brain bleed, which can do this, or whether it's the effect of drugs and alcohol. And so under these circumstances, if normal measures don't work, we have to sedate these patients to get them through a CT scan. So for this patient, hypothetically, we decided to give them an anesthetic, which is a perfectly reasonable thing to do. It's well-established routes of going through these things. Give him the anesthetic, but unfortunately, during the anesthetic, he suffers a severe anaphylactic reaction and becomes very unwell, inhales some vomit, which shouldn't have happened, ends up in the intensive care unit and survives, but, you know, pretty stormy course. And most people, when you ask them, they'll say, well, okay, that's just bad luck, isn't it? Okay, fair enough. Well, let's give you a different scenario. This is an elderly lady who's seen in the emergency department who falls over a chair at home and cuts her head. And she comes into the emergency department, someone sews up her head and sends her home, but forgets to ask whether she's on anticoagulants, so blood thinning therapy. And if I ask my colleagues what happened to this patient, they say, well, she probably had a brain bleed and died. And in fact, this patient was fine. Nothing happened to her at all. And the point about that is that when we're assessing judgment, what we tend to do in a lot of our audit processes and in a lot of our clinical practice is we look at what happened to the patient. So in the first patient, they actually had a terrible outcome, but all the judgments and the decision-making was actually really spot on. It was the correct decision. It was just unlucky. In the second one, the outcome for the patient is great. They didn't get admitted. They didn't get additional radiation. They didn't get hassled. They just went home and they were fine. But actually the decision-making was terrible. You know, that was a bad decision, but got lucky. And we see a lot of this in medicine about differentiating this difference between process and outcome. And some of the work we've done has been specifically to look at that and say, follow the patients through who you think are fine and discharged and actually work out that they're not, and vice versa. Now, many of you will be familiar with Dan Carman's work, which talks about the thinking fast and slow and talks about type 1 and type 2 thinking. Type 2 is very slow, waiting to see what happens, getting all the data. I guess what happens in rheumatology clinics and ophthalmology clinics. My wife's an ophthalmologist who specializes in rheumatological diseases, so I think I can say that. And it's really measured and slow and careful. And type 1 thinking is just pattern recognition and go. And just, I've seen this before and make quick decisions. And you often think that in emergency medicine, maybe we're type 1 decision makers. And there is something of that. But it's not really the case. There's a much better model. And what we've done is try to apply the work of the guy called Gary Klein, who's done much more work with decision makers about trying to understand how people make decisions in complex environments. And he did some really interesting work years ago where they interviewed fireground commanders and said, well, what do you do in this situation where you're going into a building, which is by its nature an uncertain event about what's going on, what's in there, who's in there, and all that kind of stuff. And their common sort of reply was, what do you do in these situations? Well, we just follow the protocol. And I said, oh, that's fantastic. And carried on doing this for a while. And then went back and said, well, you know, can you show me the protocols? And they went, oh, they're not written down. They don't exist, but we just kind of know what to do. And he was able to develop the idea that what experts are doing within complex environments are essentially modeling what will happen in their heads. If I do this, then this can happen. Doing a risk assessment of it, or doing an assessment of that, Will it work? What are the options? How will this impact where I go? Doesn't work, then going back and then remodeling again. There is a little bit of, I've seen this before and go for it. And there's a little bit of what they call shotgunning, which is, I'm not entirely sure what to do. So we'll just do all 4 or 5 options at the same time. But the point is, you can definitely explore, and a lot of literature, not in medicine, about how people make these complex decisions. And then it was a case of, how do we bring that back in to make impactful change to the decision makers that we've got? So we've already talked about this, about the point where we're talking and making our decisions and trying to improve how we treat patients in this complex phase of time critical, information light, but high stake decision making. So the first thing we did is we looked at the modeling for how we train for what we call halo procedures. So these are high acuity, but low occurrence. So this is something like somebody gets stabbed in the chest, they've got a hole in the heart, you have to open the chest, sew up the hole in the heart, and try and get them the heart beating again. Or something like a resuscitative hysterotomy, where we have a cardiac arrest in a pregnant lady, and you have to take the baby out as quickly as it's possible. And this happened last week. I think up in Yorkshire, it was on the news. Obviously, you don't want to be doing that for the first time and never having practiced it. So we've developed a structure around developing these 3 tiers. And not tiers, they're all equally important, because a lot of the training is about sort of developing your psychomotor skills, about where do you put the knife, how do you sew things up, but doing that out with developing the mental model so you can perform under pressure, and teaching people the models of how we do that, and preparing as teams. If you do one without the other, you're inevitably going to fail. So it built, you'll see a lot of triangles in my talks, this concept of how we develop people through the systems. And now we've got a great program in the Northwest and nationally about how we train people in emergency medicine through these tiers, so that when they become consultants, and even when they're consultants retraining, to develop and keep those skills in currency, so that it doesn't matter where you end up. If you're in a major trauma centre, or if you're anywhere else in Manchester, if you turn up having been stabbed, dropped off the back of a car, does happen, then somebody's there who can deal with it. So it's taking the data, taking the science and bringing it back. And then taking it even further, working with external organizations. So this is the ATTACK group who I work with, the anesthesia, trauma and critical care group. These are all models. So none of this is real. These are all made up actors, because what we found is dealing with a big rubber dolly, which is what we tend to do in simulation training, isn't real. But dealing with people who have emotions, who have conversations, who can express what's going on is really important. If you want to build within a psychologically safe area, something can happen. And even this, which is putting a surgical airway in, building models with model makers so that you can actually put the device in front of a real human. This is Hutch, who's one of our recent trainees here in Manchester, and actually develop this so you can do this on a real person and do it live. So building the relationships between ourselves and other companies. Again, this is not real, but this is the same sort of thing. So you can develop this. And the learning opportunities, when you've got that you can understand that doing a procedure is not just about the psychomotor element. It's about putting the human in there so that it can prepare under pressure and then perform, but then hopefully also be more psychologically safe. And that's what we've got back from our studies. Do a lot of stuff about Goldilocks moments in terms of when the right time to do a procedure is. And we've developed a system of celebrating success. Many systems around the world will look at mortality and morbidity meetings, which is where lots of clinicians get together and be mean to each other about when things go wrong. But actually what we're trying to do now is celebrate awesome and amazing alongside mortality and morbidity, so that we learn about when things go well rather than when they go badly. And building these programs into systems all over the world has been really exciting. And the biggest impact I think we've had in the last 5 years, which is now being adopted by resuscitation courses worldwide, is to go back and really have a look at the really fundamental elements of how we do a resuscitation. And probably up until about 8 or 9 years ago, everybody would have said that the start of a resuscitation of a severely critically ill or critically injured patient starts when you meet the patient. And working with colleagues in America, Canada, Australia, and New Zealand, we came up with a model which actually doesn't, does it? Because the resuscitation starts in your head as soon as you hear about the patient. And developing a model, this is known as the 0-point survey, I won't go through it, but developing a model that allows people a structure to organize their thoughts and their mind and their team whilst they're on the way to meet the patient, or whilst they're waiting for the patient to arrive, or even when they're just running down the corridor to a cardiac arrest, has made fundamental difference, which we've now measured and we can show that performance in real resuscitations changes. This was a PhD that was done over in Lithuania based on the ZPS that we did some advisory work with, that shows that if you input these things into a department, you get better outcomes for patients. So there's a whistle-stop tour concentrating on the education side of things. I just want to give you an introduction to how we're trying to take the science, working collaboratively, being innovative, and bringing it all together to actually make a difference to what happens on the shop floor. And finally, Steve Jobs always said there was one more thing in every presentation for Apple. He always said there was one more thing. I'm going to announce an iPhone. I'm not. I just wanted to tell you about Our Lady. So that was a complex one. That was a really hard decision. And experts came together and made a decision. And the lady, and you can read about it in the Manchester Evening News, was told that the husband was told that we may not be able to get both out. But in fact, due to complexity, judgment, understanding, making decisions under pressure, all the training that goes before, this had a fantastic outcome, and both mother and baby survived and have come back to the hospital as patients subsequently, which is an absolutely marvelous story. It just shows you that if you train well and you make good decisions, you make good things happen. Lastly, and I couldn't do it as well as Sophie. Sophie, you're so nice and you're so kind and you're so wonderful to everybody. It's another triangle from me. It's much more simple, but I can't reiterate all the things that Sophie said. You know, all of us here who get to any of these positions, the number of people who've assisted us on the way, our family, our friends, our colleagues, people like Kevin McAvoy-Jones, Dan Horner, who's a MAHSC professor, Rick Bodie, who's a professor at the university. All of these people we work and collaborate with. None of us are islands, and everything we do is such good fun to work with people and to do, you know, hopefully impactful things. So thank you so much for your time and attention. And yeah, I hope that was a little insight into why some days are more exciting, a little bit more complex, and when they go well, absolutely fantastic. Thank you for your time.
Brilliant. Thanks very much, Simon. It was fantastic. Do you want to stop sharing your screen and then we can see everybody? Great. Has anybody got any comments that they want to make? Any questions? Paul, I saw you come off mute.
Yeah, I mean, I'm sort of nudging in there. So congratulations, Simon. I've worked with Simon for many years, go back a long way, and I'm really delighted that you've been promoted, Simon, within the MAHSC chair. Very well deserved. I mean, your education input has been critically important. And in fact, we use the medical students continually, the best bets approach, which I think has really enhanced student experience, and congratulations for that. I guess a quick question: what can we learn from high acuity, low occurrence planning in the opposite? So low acuity, frequent occurrence, because I guess there are mistakes made continually in that where we don't perhaps have as much attention over.
Yes, and if you look at the where we are at the moment, then there are many of those, aren't there? I think that's a wider patient safety issue about how you communicate, how you, well, you've got to find them first, is the issues. And I think so I work with several different organizations, and the biggest influence on what your question actually is, I would say, is around culture. So with the air ambulance, which is, you know, an absolute joy, pleasure and honor to work with, it's a relatively small group of people who've got clearly articulated common goal, who all really want to be there, but are all pretty much empowered to make change. And the organization is what I call agile. And it's something that came out of COVID, I think. I've got this concept of evidence-based agility, which is EBA. I know it's rubbish, but during COVID, when we all had a common purpose, when people were empowered to make change, when they were engaged and people were willing to listen, we saw things change at an enormous rate. Almost on every second week, we were doing things differently because we'd learned, listened, changed, and had a look at it again. And we're in this constant cycle. And COVID was horrendous. I mean, I worked here, and you know, the first cohort of patients, 1 in 3 of the patients we admitted died. It was awful. You know, I never want to go back. But the innovation that we saw there was remarkable. And if only we could keep that going, if only we could keep that momentum and have the right size groups with the right attitude, I think we could do amazing things. And that's with a smaller group of really highly motivated people in the air ambulance. That's what I see. You know, I had a problem on a job 3 weeks ago. We had an M&M. It was tough. It was difficult. There were really hard conversations. The end output of that is a change in how we orientate things and equipment. We did it the next day. And that's just so fantastic. That's where I would like to be, Paul. But gosh, how do we shift these monoliths of organizations?
Any other questions for Simon? Yasmin.
Thank you. Yeah, I'm a little bit conscious about timing, but just a very quick question for Simon. Thank you so much. It was very interesting and impressive talk. So, just given your substantial roles in research and clinical practice, and also all of your professional activities, which was mentioned in the introduction, I really want to know, how do you balance these responsibilities and manage your time effectively?
Okay, that's a whole talk. Very happy to go with that one. But in big three principles. One, whenever you do one thing, try and make it kind of have 3 or 4 outputs. So if you do a review article, write a blog on it, do a podcast, go and speak to somebody, do a presentation, do a poster. So try and amplify your work to make sure it gets as many places as you can. The second thing is develop the people you work with, because work collaboratively, and that would be absolutely fantastic. And the other one is make sure you've got, compartmentalize your time. So I like to do lots and lots of things outside of work. So I've always, Fiona, my wife's a professor here in medical education. She's the hospital dean. We've got 2 daughters. We spent lots and lots of time with them. So we have playtime, which is really important, and do those things. And then we work hard. And we try and focus and do things there. But the big things actually genuinely are amplification, but more importantly than that, collaboration. Work with great people and develop great people, and you'll do great things.
Thank you so much, Simon.
I think that was a really inspirational way to end. I've just written all those down to remind myself to do all of those things. Fantastic. Thanks very much, Simon. Yasmin, do you want to finish the session?
You. So if there's no any more questions for Simon, this brings our event to a close. So thank you so much, everyone, for joining us, and congratulations again to the professors Parker and Carley. So please keep an eye out for the next lecture in our inaugural series of the MAHSC, taking place in November, where we will celebrate the 2024 MAHSC Honorary Clinical Chairs. Wishing you all a wonderful week ahead, and thank you so much for your time today.